We're going to move on now to chemotherapy, targeted therapy, and immunotherapy. I'd like to bring Daniel Catenacci to the stage. Also, please, the discussions, Craig Lockhart and Dr. Tim Nugent and Papita Awani, please come up to the stage first. And then I'd like to introduce Dr. Catenacci. He's the assistant professor at the University of Chicago, and he's also a DDF Medical Advisory Board member. So thank you very much for attending, please.
So as the others are coming up to the stage, I'd just like to thank you. It's an honor to be here today to talk to you about this topic. And just in memory of Debbie, whose inspiration lives on. So as we're prepared here, so this is a nice segue from the two wonderful talks in radiation and surgery. They were focused obviously on the curative intent in the early stages. And so I'm a medical oncologist, and so this talk will be focused more on the metastatic setting. And so this is our outline today. So you've heard a lot of the background, so we will just skip through that, and we are a little bit behind, so I'll speak a little bit more brisk, and there is video that you can go back to later. Today we'll just start with the background. You've heard about the three major subsets of the cancer, the squamous cell, which we've not been focusing on today, the junction, esophagogastric junction, and then the gastric cancer proper. There is a lot of heterogeneity in this cancer. You've heard of signet ring subsets and many other subsets, and it gets quite complex. Despite that, and despite our recognition that there is a lot of heterogeneity here, we often treat patients very similarly today, and especially with gastric and esophagogastric junction adenocarcinoma, particularly in the stage 4 setting. We have heard also that the symptoms of patients that present with this cancer, most patients present in the stage 4 setting in this country, and even if we're fortunate enough to be diagnosed in an earlier stage, there is unfortunately a high risk of recurrence after curative intent resection. So we are often dealing with stage 4 disease. So what does that mean? You've heard before that essentially with our best options, which in this setting is mostly chemotherapy, we're going to talk about targeted therapies, we're going to talk about immunotherapy, but chemotherapy is a staple for us, and it gets not a great reputation, but it really is very important to us in helping patients in terms of symptoms and survival. So you can see here that historically with no therapy, outcomes are not that good with the diagnosis of stage 4 disease. We use this median survival. You heard earlier about statistics and how we have to be careful with statistics. That's just a number. That is the halfway mark. It doesn't mean what's going to happen to any one individual. And there is a wide range around these time points. And you heard earlier, on some extremes, 5 years and 10 years are achievable. It's less likely, but possible. And so, of course, chemotherapy is used to improve survival time, but very importantly, you've heard of the symptoms, chemotherapy is considered palliative in this setting to improve our symptoms, improve pain, improve swallowing, etc. And so you can see here the response rate of first-line chemotherapy is around 40 to 45%. That means that it's shrunk on our scans at 30% or more. So it could shrink 10% and be called stable disease. So another 40 to 45% of patients will have stability of their cancer with chemotherapy, and that's also a very good thing in this setting. So what is chemotherapy and how does it work? So this is sort of just a general overview slide. On your left is sort of how cells divide, normal cells and cancer cells. Cancer is defined by abnormal cell growth and division. And so in order to do that, it needs to duplicate its DNA in all the cells. And so on the right, chemotherapy, various kinds, you've heard the panelists talking about different types of chemotherapy, can prevent that from happening, can prevent the building blocks of DNA to be made and prevent cells from dividing. So technically, chemotherapy is a targeted therapy that is preventing cells from dividing, which is the definition of cancer. However, we have normal cells too that divide, like hair follicles, bone marrow, GI tract, and that unfortunately is the collateral damage of using chemotherapy, and that's why we can experience side effects. So chemotherapy over the last decades has been demonstrated in many clinical trials to improve all the things I mentioned, symptoms and overall survival time. So what else do we have, though? Because we do know and recognize the limitations of chemotherapy. It does not eradicate the cancer, and it's a matter of time that the cancer cells learn how to grow on that chemotherapy, which is something we call resistance. So on your bottom left, there are all the different staple chemotherapy and classes of chemotherapy that we use. We often use them in combination because they work synergistically. And then there is this subset, that red piece of the pie, that is called Her2 positive, and that leads us to targeted therapy. So what is targeted therapy? So let's start with just some basic biology, and we'll just spend a few slides on this, just so we have an understanding about what targeted therapy is all about. We have many cells in our body: skin cells, brain cells, GI tract cells, etc. They all have the same DNA code in them. And in our normal state, there is a balance between the growth of cells and the death of cells. If we get a wound, for example, our cells in the vicinity get the signal to grow and heal. But when it's healed, it turns off appropriately. That would be normal. So what is cancer, and what is the problem with cancer? So the next few slides will help to explain that. One thing I want to point out on this slide is that cells signal through multiple different proteins, and that's what all those different colors are on the screen that I don't think I can point to. I guess I can on this slide. You can see that each one sort of signals to the next one like an electrical pulse, and signals to the nucleus of the cell and tells it to behave in a certain manner. And so this is a very interesting thing in life. All cells, all living things on this planet behave by this dogma of biology. They all abide by this rule, which is that DNA is our blueprint. DNA encodes for RNA, RNA encodes for proteins, and proteins are the function of every cell. Every cell in our body has the exact same DNA. But different genes in each cell are activated and transcribed to proteins. So our brain cells have a subset that are active and many that are off, and in our GI tract, it's different cells, etc. And so this would be the normal way of doing this. DNA encodes for a specific set of proteins in a specific order, amino acids we call them. Those amino acids are here. So depending on the code, that tells us exactly what the sequence of amino acids will be. This sequence then dictates how these things fold into secondary and tertiary structure, and then we can even have different proteins bind to each other called quaternary structures. That's what determines the function of a cell. That's central to biology. So what is cancer then? So cancer, we know it can be caused by a number of different things. Exposures through our lifetime, also things that we inherit and we can't do much about because we've inherited, and as a combination can lead to cancer. How is that? So this little squiggly line is called the DNA helix, and it can be changed. That special blueprint code can be changed through random changes when a cell divides, but also that can be accelerated, those changes, by different exposures through our lifetime, like radiation, like cigarette smoke, etc., infections, viruses. And so how does that work? So the changes in the DNA, as we talked about, can be manifest then in the protein. So the proteins can be altered in their signaling and turn cells on to tell them to grow inappropriately. That's what cancer is. So we have, on these nice colors here, 23 chromosomes in every cell. And on those chromosomes, there's around 20,000, 25,000 genes that we have as humans spread throughout each of these chromosomes. And there are 4 types of gene problems that we can experience, and Dr. Ilsen's going to talk about this, so I'll go through this very quickly. But essentially, we would have a normal chromosome, and on that chromosome, there's a normal gene, like there in purple. That can be changed in a number of different ways, 4 different ways. One is that you can have more copies than there should be. Normally, we should have 2 of every gene, one from mom and one from dad. Some of our patients, like in the Her2 setting that we talk about, can have 100 copies, 200 copies of the same gene inappropriately, and that leads to inappropriate activation of that gene. We can also have substitutions. So that code of DNA that I talked about, that's very important in terms of the sequence. Even if just one change happens, that can lead to a constitutive activation. The light switch is always on, signaling the cell to grow. We can also have loss of the gene. It gets deleted. So in this case, it can be by losing the brakes in the system. So you lose the brakes and you activate the gas pedal and you get cancer growth. And then the final one is called rearrangements, where parts of a chromosome can switch onto another part and create a fusion protein that's inappropriately on. So we have many times, and most patients will have a combination of multiple genes with multiple aberrations. And that's what defines the cancer in that patient that's driving it to grow. Okay? So we, again, can test for this through what's called next-generation sequencing that Dr. Ilsen's going to talk about. Of course, HER2 amplification is the one gene problem that we know about, should test for, and treat. But are there others? And we'll talk a little bit about that. So chemotherapy on the left has effect, but it also has a lot of off-target effects because our normal cells can be dividing. Targeted therapy is really looking for what is driving the patient's cancer and can we specifically target it with a specific targeted therapy. So this is an example of that. There's a picture here of a protein on the left and on the right that is going from open state to closed state to open state, making this open groove. When it opens, it signals to the next protein, okay? And normally, this would be opening and closing at a normal rate and mostly on the closed state. If you have a mutation, just one specific base pair change mutation, this can be stuck on, always open, and always signaling the cell to grow. And so the beauty of science today is that we've been able to develop drugs, chemicals, that fit into that groove, turn it off. Like we've switched the light switch off for that patient's cancer, and that would be the ideal example of a targeted therapy for a patient's gene problem that's causing this protein to be on. And that's a picture of this chemical stuck inside that groove to turn it off. So we know of HER2 amplification and its targeted therapy in this disease, but there are many other genes that are abnormally activated and lost in this cancer shown here, and it becomes quite complex. One other note is that we can do sequencing from the blood now and find DNA changes from a patient's tumor floating in the blood. And so technology today is allowing us to do this, and Dr. Ilsen will talk more about that. So we have technology available to find these genetic changes. We know of one already that should get a targeted therapy in this disease, and there are many other potential targets for which clinical studies are ongoing for today. Finally, and relevantly, is immunotherapy, which we've all heard about. So what is that? So normally, our immune system should recognize abnormal cells in our body and get rid of them. But cancer cells have learned how to evade our immune system. So how does it do that, and what's going on? And the next question is, can we change our immune system to re-recognize this cancer as being abnormal and get rid of it? And so this is a picture of a very important cell called an antigen-presenting cell. This cell lives in the lymph node and can get little pieces of protein from our tumor or any other thing in our body, but from our tumor specifically, this orange thing represents something unique from the cancer, one of those DNA changes that's unique to the cancer. This cell takes it in and then puts it up on the membrane here in a receptor called MHC. We have many lymphocytes in our body that are the blue cell there, that if just one can recognize this abnormal protein, it would bind there and proliferate. And we'd get many lymphocytes that look like this, and with the intention to go back to the tumor to kill it. So the first layer of the way that a cancer can evade this is to express a CTLA-4 on the T cell. CTLA-4 then actually inhibits this learning process and turns this off so that this cell does not divide and become expanded. So we now have drugs that can reverse this. An antibody called an anti-CTLA-4 antibody can come in here, block that, reactivate it, and turn this back on. So this cell can now continue to learn, to grow about that protein and expand. So we have many of those. Now those cells go back in the bloodstream, go back to the tumor, which is indicated down here, and it recognizes it as being abnormal and kills it. That's what we would like it to do. However, at this level, there is also a checkpoint, and that is PD-L1 that is expressed on the protein, on the surface of the cancer. And that binds to PD-1 on the lymphocyte and turns it off. So this is its force field to defend itself, the cancer, okay? Again, we have drugs now, antibodies, that can come in here and inhibit that so that this now becomes active again and continues to kill the cancer. That's what immunotherapy is in terms of checkpoint blockade. So what about this cancer? How has this become effective? So this is a subset of gastric cancer that's called MSI-high. It's very important. And this was a pivotal study that included many cancer types, not only gastric cancer, but 12 cancer types total. All the different colors represent different cancer types. And what you see here is that in patients with stage 4 cancer that had very refractory disease to multiple therapies before, had long-term survival in many cases, and even after stopping the drug at the mandated 2-year mark, continued to be survive without any evidence of cancer. And so this has been very revolutionary, and you can see here that what we call a plateau at the curve is that there are patients that seem to be having very long-term benefit from these drugs. So what is the relevance to this cancer? You can see here gastric cancer is this little part. In the metastatic setting, though, it only accounts for around 3% of patients. But if you're one of those patients, we would like to know that because this drug is now very effective in these patients with the response rate of around 60% of patients will have this type of benefit as indicated here on this curve. Many patients responding, a few that did not. So again, to remind you, first-line chemotherapy response rate's 40%. This drug seems to have a response rate in the 55 to 60% range for these patients. So again, something not to miss. Another study corroborated that called Keynote-59. Again, they're not a large subset of the disease, but with 55% response rate. So what about the other 97% of patients? So this was another pivotal study called Keynote-59, where 250 patients were enrolled. And you can see here that the response rate to the PD-L1 positive patients was around 15%, and the PD-L1 negative patients were about 6.4%. It should be noted then that this led to an approval for these patients. Another thing to note is that MSI-high patients were included in this subset. So if you exclude those from the analysis, because we already knew that they benefited, around 13.3% of patients will have a response rate if they're not MSI-high but are PD-L1 positive. So that translates into around 2 to 3 patients out of 20 that can derive a response to these drugs at this time. And that led to approval in September of last year for the third-line setting of PD-L1 positive patients. So this is now in our armamentarium. For your understanding, another drug, that was pembrolizumab, the Keytruda. Another drug that is the similar class, that does the same thing, binds to PD-1, is called nivolumab or Opdivo. This study was done in Asia. It's been approved in Asia based on this overall survival outcome, but not in this country to date. So the only approved therapy is pembrolizumab for third-line therapy in PD-L1 positive patients, or in second-line therapy and higher for MSI-high patients. So we had a few setbacks since then, and one of those was in this study called Keynote-61, which is a study that was randomizing patients to paclitaxel standard chemotherapy in the second line versus pembrolizumab. And unfortunately, it was a negative study, and it highlights the importance of chemotherapy in patients. Chemotherapy was better in most of these patients, and so as much as we would like immunotherapy to be effective, the reality is that it's not in most patients, at least to date. Another study that was a setback is a third-line study, which was randomizing patients to yet another immunotherapy checkpoint, avelumab, to standard chemotherapy, and this also was recently reported as negative in the third-line setting. So these are things to sort of take into account. We have a number of ongoing studies in the first-line setting and other settings. We have a number of studies with other combinations of many immunotherapies, targeted therapies, chemotherapies, and there's a lot of hope for the future, and we're investigating this rigorously. There are also vaccines that are being developed. There are also CAR T cells, which you may have heard of, and other strategies to try and harness the immune system to help us fight this cancer. So to summarize, we have treatments for both the curative setting, chemotherapy is very important there, and in the metastatic setting for palliation. We've done many clinical trials to help us understand which is the best way to go. Genetic testing of tumors helps us find the genetic events and target them. And immunotherapy holds great promise. There are subsets of this cancer that definitely need to get this therapy, like MSI high. PD-L1 positive has a little bit lower effect, but still is approved. And then we have our work cut out to help patients that are PD-L1 negative and microsatellite stable. And trying to find the right patient for the right treatment is our goal and our objective to date. So this is Chicago, the University of Chicago, and I live in there somewhere. It snowed 2 days ago, so this is the summertime. So it's very nice to be here and happy to answer some questions.
Thank you so much, Dr. Catenacci. What a great overview and simplifying what chemotherapy, targeted therapy, and immunotherapy is. I'd like to introduce our other panelists. We have Dr. Albert Craig Lockhart, who's Professor of Medicine, Chief Division of Medical Oncology, Associate Director for Regional and Strategic Clinical Research Affiliations at Sylvester Cancer Center. Thank you so much for being here. We also have Dr. Tim Nugent, who's a medical oncologist at the Maroney Cancer Center at the Cleveland Clinic, Florida. Thank you for joining us. And we have Papita Alwani, who's a caretaker as well. So I'd like to open up to questions. We have one in the front there.
As you can see, I've come with many questions.
Thank you.
Being HER2 positive, is that a double-edged sword, meaning it means your cancer is aggressive in nature, however, there is a targeted therapy for it or treatment for it?
In certain cancers, breast cancer in particular, being HER2 positive usually signifies that the cancer might be a little bit more aggressive. In gastric cancer, the studies have been mixed. Some suggest that it might be a more aggressive cancer, and some suggest that it's not. I would say that there have been some longer-term studies that maybe there may be some risks that HER2 positive tumors spread in a different way or to different organs compared to the other ones. But as far as it being a worse prognosis, that has not entirely been confirmed. Now, the positive part is that you do have an extra targeted drug that you can give. You can add, at least initially, you can add trastuzumab to standard chemotherapy, and the bang for the buck is improved. I mean, the tumors tend to respond better, and patients tend to live longer when you add that particular targeted drug to a backbone of chemotherapy.
I have one more question. Chemotherapy administered over a longer period of time, meaning versus a one-session, 3-hour, we're going to hit you with a dose of chemo, versus I'll administer the chemo over a 24/7, 5-day period. Have you, is there a reason for the difference?
Well, some of most of the treatment we use through clinical trials that's been studied. So you have to balance between the toxicities and the efficacy. So some of these treatments that's been a standard of care shows the benefit that you use a short course of chemotherapy, like the common one is the Folfox, that the pump that we carry for metastatic disease, that's given to 2 days every 2 weeks versus something that's for the 5 days that they used to be used. If there's equivalence in the efficacy of the treatment with less side effects, and that's what we pick.
Any other questions in the audience? So what I'd like to do now is, Papita, can you share a little bit about your experience with your father's treatment who had esophageal cancer?
So my dad went through chemotherapy, and after the chemotherapy stopped working, we were advised to try a drug called Keytruda. And what I can say is what the doctor said before, Dr. Ben David, that it was very important to be in a facility which had access to clinical trials, and our facility did have access to clinical trials. So also another very important thing is to have the support team in the clinical trials to help you go through the genetic testing, help you fill out the paperwork, because you're trying to manage his care, get him on chemotherapy, get him off of chemotherapy, help him feel healthy, feel good, and then there's all this paperwork to fill out to be trying to get onto these clinical trials. And it was very important to have a support staff to help you do that, and thank God we had it. So my dad was approved for Keytruda for compassionate care. Let me tell you, though, what the other doctor said, it was not a magic cure, because I saw the Keytruda, he only had a couple doses of it, and after that, he went down. So as much as we want to say, oh my God, this was the magic pill, the magic cure, it ended up being the silver bullet for him. I mean, it could work for other patients. Maybe it was his age, maybe it was how advanced his disease already was. But, I mean, I agree with you, there has to be more studies done on it, and it is a different therapy for different people, and it just didn't work for my dad. But it's not, I mean, what I'm saying is to please go to a facility that maybe will give you hope, will offer it, and at that time, you'll try anything just to prolong, and you have that little glimmer of hope, and that was what kept us going.
I couldn't agree with you more, obviously, that, we know more today than potentially when this was happening, because we learned. Yeah, and so even the 2 studies I just mentioned that were negative, we learned of these a few months ago, right? So we always learn more, and it's an iterative process, meaning we're always sort of going back to the drawing board and saying, okay, it works for these patients, but not these ones, what's going on, let's figure it out. And so you're right, like the bottom line is that immunotherapy is just not blanket statement for everybody, and we need to think about it a little bit more critically than that.
Is there a way? Is there a way? Debbie was treated with 2 immunotherapy drugs. She developed 2 autoimmune diseases, colitis and arthritis. Is there a way, has anybody determined whether, prior to administering these immunotherapy drugs, to determine who is sensitive in that respect prior to the drug given?
It's a very good question. It's an area of active investigation. We should note that patients that were on these studies were not allowed on study if they had a known autoimmune problem, for obvious reasons, that if they already had autoimmunity, if we're unleashing the immune system, it could get much worse. However, I didn't get a chance to mention, there is a 5% rate of severe autoimmunity that can be as consequence of these immunotherapies, and that's because if you remember my cartoon where the tumor cells expressing this PD-L1 protein to evade our immune system, that's how some of our normal cells evade our immune system. And so if we're blocking that, then our immune system can attack our normal cells. And some of those common cells are, as you mentioned, the endocrine cells like our thyroid and our GI tract like our colon, so we get colitis. So, but beforehand, it's hard for us to predict who will and won't have this issue, and that's an area of active investigation. We don't know.
There's one caveat about developing autoimmune disease through immunotherapy. I mean, there's been reports, especially with the cancer, that you develop autoimmune disease, that you tend to benefit from autoimmune drugs because it stimulates the immune system to act, and that should also treat the cancer. So people who had autoimmune reaction to the immunotherapy had stopped the immunotherapy, but they still had control of the cancer. So it's not always a bad thing as long as you can control it well.
Also, in the in the drug development field, there are a lot of different immunotherapies that are coming forward, and what we're learning is that they have different side effects, and they have different the incidence is different as well. And so, as we said, as we learn more, we get better at these things, and that we hope that immunotherapy in the future will be less toxic than the immunotherapy that we have now, even though currently, right now, immunotherapy compared to some of the other therapies is pretty well tolerated. But I would hope that in the future that those things will get better as well.
I have a question for the panel myself, being an immunologist. Is chemotherapy given at the same time as the immune agent, or is it sequenced, and how do you know which one would come first?
Look at me. It's a great question, but currently right now, the approvals of immunotherapy are as monotherapy. So pembrolizumab is given by itself as its own therapy at the moment. There are studies now that are either ongoing or completed and we're waiting for the result, combining immunotherapy with chemotherapy in this disease. And they were given at the same time, like the same day. You give it, this in sequence on the same day. I believe it's the immunotherapy that went first, and then you give the chemotherapy, et cetera. So in other tumor types, lung cancer was a big one this week that was approved in the first-line setting for first-line lung cancer with chemotherapy. So we know they can be synergistic, and we eagerly await the results of some of our combination studies to see if that will be beneficial.
I mean, the paradigm was that you need the immune cells to actually do the work. When you give the immunotherapy, there have to be immune cells sitting there to actually do the job. And so the concern was always that if you're giving chemotherapy, you're going to knock out the immune cells, there won't be anything to do. But then the studies in lung cancer have proven
Turns out to not be true.
that that's not true. And so again, we're waiting to see what will happen in this particular cancer. Gastric and GI cancers tell us all the time that we had similar ideas in breast cancer with HER2, and turned out we're not breast cancer. And then so I don't know. We'll have to see what happens with these studies.
Any other questions from the audience?
There's one.
Please go ahead. Please use the mic.
Oh, sorry.
Thank you.
When are different institutions using the role of a, quote, liquid biopsy versus just a tissue biopsy and using that to help direct systemic therapy?
I'll take that one on because I brought it up, and maybe it'll be discussed in the next talk too. So liquid biopsy was that thing I was mentioning where you could draw a blood test and find the DNA of the tumor floating around in the blood. And it's more new. It's a newer technology. It's been around for just a few years, and many studies are showing that it can be a non-invasive way to find the same things that we would get from tissue. There are differences between the two assays in terms of what you can and can't do and what you have to be aware of. And today I use them complementary. I don't use one to substitute the other. I think they can provide different information. This disease, this gastric and esophageal cancer is one of the worst in terms of disease heterogeneity within the patient. So in other words, patients can have spots of cancer that are HER2 positive and other spots that are HER2 negative. And so if whatever you happen to biopsy would be what you'd get the answer for. On the other hand, if you do it from the blood is a representation of all the cancer spots in the patient's body. And so you get a representation of sort of what's going on throughout. And I think over the next years, there are now many publications showing this. But I think over the years, especially in this cancer, this may be a useful tool to address that problem in this particular cancer. It's on the cutting edge at the moment, but this is the future, I believe, going forward.
Okay, well, thank you very much. And we're out of time right now. All of you who are online or that hear and want to ask some more questions, please see Mary Margaret in the back. So thank you very much for your presentation today. I'd like to take a quick picture and start on our next round of presentations. Thank you.